Dear colleagues, in partnership with NDT, Nephrology Dialysis Transplantation, the official journal of the European Renal Association, MARKUS HOMe welcomes Dr. Deborah Clegg in El Paso, Texas, and Dr. Biff Palmer in Dallas, Texas, in order to discuss management of hyperkalemia, which is the topic of a novel treatment standard paper in NDT, selected by the journal's editor-in-chief, Dr. Anders, and by Andreas Kronbichler and me as our NDT's pick of the month for a detailed discussion at MARKUS HOMe. Dear Debbie, dear Biff, it's a privilege to host the two of you tonight. Thanks for being our guest.
Oh, thank you.
Thank you very much.
Dr. Deborah Clegg is Vice President for Research at Texas Tech University Health Science Center, El Paso. She is a PhD in nutrition, and her clinical and academic work focuses upon obesity, sex hormones, and metabolism, with a special interest in the interaction between nutrition and physiology. Dr. Biff Franklin Palmer is nephrologist and professor in the Department of Internal Medicine at the UT Southwestern Medical Center in Dallas. His academic work focuses on physiology and pathophysiology of human electrolyte regulation. Together, Dr. Clegg and Dr. Palmer have co-authored numerous papers in leading nephrological and medical journals on potassium disorders, including several New England papers. And together with Andreas Kronbichler, outside nephrology, Dr. Clegg and Dr. Palmer share a passion for mountaineering. You may find videos of some of their climbs on their private YouTube channel. And we would maybe briefly come back to that at the end of our video, since Dr. Palmer is, to our best knowledge, the first nephrologist who climbed the Mount Everest. And he is arguably the only nephrologist who did all the 7 summits, the highest peaks of all 7 continents, following the Messner list, which I learned yesterday is even more challenging than the BARS list. But first, back to nephrology. And again, it's a pleasure to host the two of you.
Well, thank you very much. And on behalf of my colleague, Dr. Deborah Clegg, we're very honored to be able to make this presentation. And we invite the readership to read the article, Hyperkalemia Treatment Standard. I've provided the reference here in my title slide. I wanted to begin by putting the talk into perspective by just briefly reviewing normal potassium homeostasis. I think, as everybody is aware, a typical 70-kilogram individual has roughly 3,500 milliequivalents of total body potassium, most of which is found in skeletal muscle, and really only a small amount in the extracellular fluid compartment. And it's this really large gradient from inward to outward that sets the cell voltage. And that's why disturbances in plasma potassium largely give rise to manifestations in excitable tissue, like cardiac tissue and neuromuscular tissue. Just briefly, imagine that somebody's ingesting 100 milliequivalents of potassium. The kidney is primarily responsible for maintaining the total body potassium content, but there is a small contribution of the colon, roughly 10%. Now, as you well know, as people lose kidney function in a progressive manner, the contribution of the colon progressively rises. And by the time you reach hemodialysis or some form of kidney replacement therapy, as much as 50% of potassium is excreted via the colon. And at least anecdotally, it's been observed that a dialysis patient, for example, that undergoes a colectomy, they have a lot more problems with hyperkalemia because you're removing a major site of K homeostasis. Now, it turns out that following an ingestion, the kidney's ability to excrete a load is a little bit sluggish. It takes about 4 hours. So to guard against an excessive rise against extracellular fluid concentration, we initially shift potassium into the cell. And this then allows enough time for the body to reestablish total body K content. The 2 most important factors that are involved in that shift of potassium are the release of insulin and beta-adrenergic stimulation. So following a meal, we not only release insulin to maintain the plasma glucose, but it also serves this defense of allowing the kidney enough time to handle the load by shifting K into the cell. Beta-adrenergic stimulation, this primarily plays a role, for example, in exercise. Exercising muscle, there's a lot of potassium that accumulates in the interstitial compartment. But so that that's not excessive as we activate autonomic nerves with exercise through beta stimulation, this keeps the amount of K in that interstitial compartment largely within a physiologic range. I would just add the accumulation of potassium in the interstitial compartment of exercising muscle is very important because that actually exerts a vasodilating effect. And I think this largely explains why total body potassium depletion becomes a risk factor for rhabdomyolysis, because you lose that vasodilating effect of potassium. Remember that potassium is freely filtered across the glomerulus, largely reabsorbed in the thick limb and the distal tubule. And then it's this component of K secretion. This is the component that is largely regulated and varies according to physiologic need. I would remind the audience the three main determinants of that potassium secretion are the release of mineralocorticoids, having an adequate amount of sodium being delivered, and also flow rates. Sodium and mineralocorticoids playing an important role in the generation of that lumen negative charge that drives potassium secretion. I would also just out of interest say that there's a lot more insight into what's going on in that distal nephron. People have now described the initial portion of the distal convoluted tubule as a K sensor, such that with rises in extracellular K following a meal, for example, even within the normal range, this would exert a depolarizing effect in that initial portion of the DCT. And because it's now less negative, there'd be less of a driving force to extrude chloride. And this slightly rise in chloride in response to a slight rise in extracellular K concentration regulates these proteins in such a way that you get an inhibitory effect on the thiazide-sensitive sodium chloride cotransporter, and therefore augmenting K secretion in the downstream segments, both electrogenically and flow-mediated K secretion. So with that background, I'll turn our attention really to the paper. In the paper, we define and try to distinguish what we would say would be acute hyperkalemia from chronic. We define the acute hyperkalemia as that which develops rapidly. It tends to, because of its rapid development, be more life-threatening. And manifestations, again, can range anywhere from muscle weakness, paralysis, but importantly, life-threatening arrhythmias. This is a part of the figure in our paper. And one of the things we review is, at least in a superficial way, is how some of the EKG changes come about. Remember that the initial rises in extracellular K concentration will cause a depolarizing effect on the cell membrane, so that now the resting membrane potential becomes a little bit closer to the threshold potential. And this creates now an increase in cardiac conduction because it takes less of a stimulus to cause that phase zero sodium-dependent depolarization. That's illustrated here. And this initial manifestation gives rise to the peak T waves. Now, with progressive rises in extracellular K, as that resting membrane potential becomes very close to the threshold potential, interestingly, you start to shut off these sodium channels and you activate what have been described as inwardly rectifying potassium channels. This actually slows cardiac conduction and is thought to account for some of the later changes, QRS complex widening, and ultimately the sine wave pattern. We discussed some of the therapies, obviously the release of, or the administration of calcium as a way to stabilize the cardiac membrane. One of the thought is that calcium, by causing a widespread deposition of a positive charge, it creates a slight repolarization effect, either diffusely or because it's actually specifically interacting with these phase zero dependent sodium channels. The next step we mentioned is obviously the release or administration of insulin and an administration of inhaled albuterol. These obviously are important in shifting potassium into the cell. Insulin works quite rapidly and lasts for about 3 or 4 hours. Beta adrenergic stimulation also works fairly rapidly and acts several hours. One point I'd like to mention is that insulin and beta adrenergic stimulation work because they increase the activity of the sodium potassium ATPase. Here you can see the pathway by which beta adrenergic stimulation does that. and here the release of insulin through a separate pathway, obviously. One thing it's worth noting is that insulin can activate the NAK ATPase here through this pathway that's independent of its glucose regulating function through insertion of glucose uptake protein. This actually explains why, for example, in obese individuals who are insulin resistant still have susceptibility to the administration of insulin to enhance K uptake. These are two separate pathways. So in other words, you can be insulin resistant, and yet insulin still seems to have an intact function to cause K uptake. Following the stabilization of the cardiac membrane and the shift of K into the cells, one can then turn the attention to decreasing total body K content. Obviously, if you have no kidney function, hemodialysis would be indicated. One can try high-dose diuretics, or if the patient has acidemia, try to correct the acidosis. And one of the things we mentioned in the paper is K-binding drugs, while they're not indicated for the treatment of acute hyperkalemia, they can certainly be used as an adjunct. In other words, given along with the more traditional therapies. We then define chronic hyperkalemia as that which develops over a more extended period of time, often for weeks, months, or even longer. As the audience well knows, this tends to be oftentimes recurrent because the underlying disorders are still present. It's well established that hyperkalemia, in really somewhat of a graded way, is associated with worse outcomes. And particularly if you associate with any given level of potassium comorbidities, those outcomes even become worse. It's not to say that that the hyperkalemia is the direct cause of the mortality, for example, in this type of paper. It may be, in fact, the underlying comorbidities that are driving the mortality, but nevertheless, the association is quite strong in various papers. We then discuss quite extensively these more chronic therapies, and I'll just mention a couple of these. One of the things we would say in anybody with chronic hyperkalemia, you really have to review the medications, and anything that really interferes in the renin, angiotensin, aldosterone cascade can be a culprit in chronic hyperkalemia. For example, NSAIDs, one of the more common offenders. That's because prostaglandins normally stimulate the release of renin from the JG cells, and so NSAIDs suppress renin release. The beta blockers can do this, the calcineurin inhibitors. Patients with diabetes who have hyporeninemic hypoaldosteronism thought to have microvascular disease of the afferent arteriole. And then as we age, interestingly, there's an age-related reduction in the ability to release renin. The one drug that inhibits the enzymatic activity of renin called the liskrin works here. The ACE inhibitors obviously lower aldo by blocking at this point. The ARBs block the AT1 receptor on the zona glomerulosa cells. We have processes that interfere in aldo biosynthesis. Obviously, in a hospitalized setting, heparin, the azole antifungal. We have this new class of agent, aldo synthase inhibitors, that are now being developed. That may then be added to the list here. Aldosterone receptor blockers, to include all of these. I throw out here drospirenone. It turns out that the progestational agent found in some birth control pills can actually interfere in K homeostasis through mineralocorticoid blockade. And then anything that interferes in that movement of sodium and the creation of that negative charge will also be a culprit. So it's always worthwhile reviewing the medication list in approaching somebody with chronic hyperkalemia. The next thing we discuss is dietary K counseling, and I'm going to turn it over to my colleague to maybe mention a few things in that regard.
Thank you, Dr. Palmer. So I'm going to start with this chart here, and so I'm coming to you from my experience as a renal dietitian or a nutritionist, and so I see patients, and they're oftentimes given a list such as this when they're in their nephrologist office, and they're told avoid all of these foods, and I will have to admit to you that I absolutely can't stand these lists because they don't really tell us a lot. What they do tell us is that these are allegedly foods foods that might be relatively high in potassium, but much of the information on here is devoid of really true content. For example, a fig dried. I mean, what is that? Is it a whole fig, a half a fig? And the other part of this is that these have been taken, these are the amount of potassium that is alleged in these food types. And the reason I bring this up is that there is new data to suggest that with global warming and the changes in our agriculture system, that these lists are actually not accurate, that the food products that we are currently consuming, especially if they're fresh, might actually have less potassium than is what's listed on these currently on a chart such as this. So that's point number one, and that is that these are old and they're outdated, and really they need to go in the bin. They need to go in the recycle bin. The other thing is that oftentimes our patients come to us and they know that they've been told to eat a heart healthy diet, and so they've been, this is something that they want to do. They maybe want to lose some weight or whatever it happens to be, and then they're given a list such as this, and all of the foods that they were previously told to consume are now on this list, and they usually throw up their hands and they're like, well, what am I ever going to eat? And they become wholly dissatisfied, and it becomes a really unfortunate situation for them because they absolutely have no idea what to eat. The other issue I'd like to bring up is the fact that these fruits and vegetables that are listed on this are the very ones that actually add bulk to our diet. They're actually higher in fiber, and they're the ones that would help us rely on that other half of the potassium homeostasis, which relies on the gastrointestinal tract. So we take away all these foods, we basically cause our patients to be constipated. They're also woefully dissatisfied with the types of foods that they're eating. And yet, what do we do? As soon as we find someone who has an elevated level of potassium, we blame them for eating a food that was the cause of their elevated potassium. This also establishes an unfortunate relationship between the nephrologist and the patient. So I'd like to throw all of this out the window and say, let's have a new approach. The other aspect of this list that I think that we need to spend a lot more attention to is the fact that when we start processing our foods, all of a sudden we add a large amount of potassium, and this potassium significantly, I'm going to use the word it enhances overall bioavailability of the potassium. So if you eat a piece of bread that's been highly processed, the potassium in that bread is going to increase serum potassium much more readily than if you actually had a piece of wheat bread that perhaps that was not highly processed. On this list, it lists things such as salt substitutes and salt-free broth. Oftentimes, our patients are looking for something to flavor their foods. They may grab these, but these are loaded with potassium, and they don't even realize this. And again, I think what we really want to advocate is let's have a better conversation with our patients about the types of foods that they're eating, so we can have a more nuanced approach about asking them about the types of foods that maybe we would make some recommendations about that they avoid to overall help their overall potassium homeostasis. And this is just a relatively recent study, and there's been so many newer studies that are coming out that are demonstrating that where we used to think eating a heart-healthy diet that contained fruits and vegetables was bad for a patient with kidney disease, there are newer data that suggest that actually increasing urinary potassium is actually good for our patients. And this is just another study, again, relatively recent, and there's so many more that have been coming out that suggest that when we have our patients and they actually eat diets that are higher in fresh fruits and vegetables, this is associated with a lower all-cause mortality. So what I'm really trying to advocate for is that I think we need to now rethink this. And basically what has happened is that our patients are sort of and you as nephrologists are in this catch-22. We see a patient, they come into our emergency room or into our clinic with an elevated level of potassium. We reflexively blame them. We said, oh, you ate a banana before you came here. Now, not necessarily do we know whether they ate that banana or not, but I think what we might want to do is say, okay, so maybe you had a half a banana, but what other foods did you have? Do you love bananas? Would you like to keep a half a banana within your diet? Maybe we can find some other foods that we could take away so that you could actually eat the types of foods that you love. Because I think that this type of relationship will set us up on a course where we can improve overall patient compliance, we can improve their overall mood, and also their outlook on life. It's really, really challenging to be a patient and have all of these restrictions imposed upon us. And I think that we need to now think about it in a different type of way. So with that, I'll turn it back over to Dr. Palmer.
Well, thank you, Dr. Clegg. So after reviewing medications, after in a more nuanced way examining the diet, I think there's no question that good diuretic therapy can be an effective way to help ameliorate the tendency to hyperkalemia. This also has the advantage to help blood pressure control. I always remind clinicians, if you're going to use furosemide, remember to always use it at least twice daily. It's a short-acting drug. If somebody has metabolic acidosis, correcting the acidosis can have a favorable effect. In the absence of acidemia, however, the effect of sodium bicarbonate is somewhat muted. Obviously, one could decrease or discontinue renin-angiotensin system blocker, but I think most people are now aware that our guidelines are really telling us this is another one of these catch-22s. On the one hand, if you cut down the dose or discontinue an ACE, ARB, or aldosterone antagonist, yeah, the hyperkalemia may improve, but now you're giving up all of the cardiovascular and kidney benefits of those drugs. And so most guidelines are now recommending that we try to, at all costs, maintain optimal dosing of these drugs and try to address the hyperkalemia and other means, for example, use of potassium binding agents in some individuals. The other thing, though, that helps in that regard is simultaneous use of SGLT2 inhibitors. Now, SGLT2 inhibitors are not indicated to prevent hyperkalemia or ameliorate it, but many of the patients who are on ACE, ARB, or aldosterone antagonists have indications for the utilization of these drugs. And as you may be aware, these drugs clearly seem to minimize or ameliorate the tendency for ACE, ARB, induced hyperkalemia. This is one meta-analysis of some of the big SGLT2 inhibitor trials. And you can see here the effect of the SGLT2 in lessening serious hyperkalemia was reduced in virtually all of these. The time to first investigator-reported hyperkalemia also reduced. We recently wrote a paper as to some of the mechanisms that may be involved. And they're really kind of interesting. SGLT2 inhibitors have a number of effects that increase K secretion, obviously by inhibiting sodium-coupled glucose co-transport. You have higher now sodium and flow to the distal nephron. That's going to enhance K secretion. The inhibitory effect on sodium-coupled glucose co-transport, interestingly, also has an inhibitory effect on the proximal sodium proton exchanger, thereby causing more bicarbonate to reach the distal nephron. And if you remember, alkalinization of the distal nephron allosterically modifies the ROM-K channel, thereby enhancing K secretion. The effect of glycosuria to cause an osmotic diuretic effect would also facilitate. And interestingly, as you lower plasma glucose, insulin levels fall, glucagon levels go up, and there's a whole literature that glucagon actually directly interacts in the tubule to enhance K secretion. At the same time, SGLT2 inhibitors have a number of effects to limit K secretion. They dampen the RAS system through tubuloglomerular feedback. There's data, for example, that increased delivery of glucose to the DCT1 cell that I talked about earlier can actually augment sodium chloride co-transport, thereby limiting downstream sodium delivery. And there may be this paracrine effect. So the bottom line is there's multiple effects of these drugs on kidney K homeostasis, but it appears that the net effect is limiting hyperkalemia. Lastly, I would just mention that K-binding drugs can certainly be useful, and we discussed that in the paper. At least in my opinion, drugs like sodium polystyrene sulfonate or K-exalate are really not viable for long-term management. That's why there's been a need for newer agents, for example, the two new drugs, patiromer or zirconium cyclosilicate. This is just an illustration of how patiromer works. This is administered as a polymer. It travels downstream, and it was designed to primarily work in the colon. And so what it does is it binds luminal potassium, thereby limiting the free potassium in the colonic lumen, thereby favoring passive secretion, as you can see here, favoring active K secretion. and also limiting any K absorption in the last part of the colon. It binds potassium in exchange for calcium. That calcium binds to either carbonate or phosphate. It is excreted into the urine. However, there is a little bit of calcium absorbed. And one of the things that's been noted is that there's a little bit of magnesium binding. So in some of the clinical trials, about 5% of patients can get hypomagnesiemic. The utility of this drug, though, has been illustrated now in long-term follow-up. In the study by Bacris, you can see patients maintained on patiromer maintain normal kalemia. I point this study out because 100% of these patients were on renin-angiotensin aldosterone antagonists, and yet were able to maintain normal kalemia. Going back to this idea that guidelines tell us we should maintain doses that are optimal of renin-angiotensin system blockers in patients who may benefit from them. The other drug, zirconium cyclosilicate, I just point out that in one of the pivotal trials, you can see that it really rapidly lowers the extracellular K concentration in the first 48 hours of therapy when given 3 times per day. The first statistically significant time point here is at 1 hour. And it too, in this study by Spinowitz over a 1-year period, again, showing maintenance of normal kalemia. About 2/3 of these individuals were on renin-angiotensin system blockade. So let me just summarize some of the salient points of the paper. Again, remember with chronic hyperkalemia, look over those medications, use good diuretics, correct metabolic acidosis. Be a little bit more nuanced as to how you might restrict potassium. Not all drugs are equally as offensive. Remember, as Dr. Clegg pointed out, the idea of processed foods really being enriched in potassium and having more bioavailability. The same thing with renin-angiotensin system blockers. I think there's no question. Guidelines tell us we need to maintain optimally dosage of those drugs. The use of SGLT2 inhibitors, I think, is going to help us to maintain optimal dosing of these agents. And when that's not sufficient, one has also the ability to use these new binding agents. They've been now shown in 1-year trials to be enabled to enable the use of the drugs that we're trying to achieve. So again, we thank the audience very much for allowing us to participate in this discussion.
Well, thank you very much. It was a great presentation, and it's actually mimicking the flow of the paper, which is exceptional to me. It's easy to read. The figures are nicely designed. And so it's a really, really nice must read actually for the readership. I've 2 quick questions. So in terms of chronic hyperkalemia treatment, when you use patiromer or sodium zirconium cyclosilicate, how often do you see episodes of hypokalemia then?
Yeah, that's a great question. You know, you would think that you're giving this drug, it binds potassium in the lumen, and yet in the clinical trials, while the potassium comes into the normal range, in only a very few people that has ever go below normal. So it can occur, but it's very uncommon. And I'll just give you my own theory as to why that occurs, why we don't see it more commonly. Remember that hyperkalemia obviously has a direct stimulatory effect on aldosterone release from the adrenal gland. And aldosterone is a hormone that is known to promote colonic potassium secretion. So what I think is going on is that as you treat the hyperkalemia, that stimulatory effect on mineralocorticoids is now removed. And therefore, you get less colonic K secretion as the K comes into the normal range. In other words, this reduction in mineralocorticoids that occurs as you treat the hyperkalemia, in essence, places a floor on how low the plasma potassium will go. It's purely a theory, but I think it's been striking that in these trials, only a very few people ever get hypokalemia.
In terms of diet, I think one of the issues was when I started renal medicine was basically going through all the lists and then blame the patient. Why do you not follow our advice? But I'm very glad that we are moving away from that. We had recently a colleague from Texas actually talking about fatigue in the CKD stage and dialysis stage. Do you think that, with more liberal, let's say, food intake diet, we can also improve fatigue in our patients.
I think absolutely right. I think that the diet is so draconian. It's horrible to follow, and it's not very healthy. And so actually, we probably have forced our patients to eat more processed foods because we've told them not to eat the fresh fruits and vegetables. So we've converted them. We've told them to eat these highly processed foods, which are super high in potassium, but cause fatigue and they don't feel good and they have constipation. I think we've actually created our own problem. And I think if we now step back and say, oh, let's reassess this, let's get them back on a healthy diet that includes the fresh fruits and vegetables, that there will be less fatigue and that they will be so much happier with us and we'll have a better relationship in the long run.
Dr. Clegg, didn't you remember, I think you told me about a patient you were once referred to whose main complaint was they had no energy. And,
exactly. Yeah. Dr. Backrus specifically referred a patient to me and he'd lost a lot of weight because there was nothing for him to eat and he was so depressed. And so he'd had this massive amount of weight loss. He was depressed, chronically fatigued, and it turned out that he owned an avocado plant, and they took away all his avocados. And so it's like, okay, let's talk to you about, can we add an avocado slice here, an avocado slice there? His mood brightened up. He gained a little bit of weight back. He ate a more healthy diet, and all of a sudden his fatigue was gone. It was just like, it was revolutionary. So I think it's really important that we go back and we address this type of issue with our patients.
And then one last one from my side before handing over to Gunnar. So you're writing in the paper, the amount of insulin you're using, that basically depends on the recommendation guidance, and it's between 5 and 10. Is there a good evidence base for one of the doses, or is it more like, experience from observational studies?
Yeah, in reviewing the literature for the paper, there was a little bit of, I don't know that there was any one consensus. I saw some papers trying to compare, is 5 better than 10? And I don't know that there's a right answer, to be honest with you. One consensus group concluded that 5 was just as good, and that was their final recommendation. But as we mentioned in the paper, it was kind of opinion-based at the end. So I will be honest with you, in my own practice, I've oftentimes given 10. And but you do have to be worried about the potential for hypoglycemia. And that's obviously why we give glucose along with it. But I don't know that we have a true evidence-based answer at this point. Yeah.
So thanks so much also from my part. This was excellent. And actually, Andreas, Markus Seemann, and I discussed for months that we should address this issue of dietary intake. And now we have it within this video, so it's great. Let me maybe start with 2 or 3 questions on nutrition again. So would you still recommend our patients to limit their intake in fruit juices? I'm really enthusiastic about this more liberal recommendations now, but what about juices?
I thank you so much for that question, because I also like to limit fruit juice consumption. I think people overdo it. That the serving size is a half a cup, which is so incredibly small, and people don't typically, I mean, your glasses at home have grown, right? They're much larger, and so you fill up your glass with some juice, and all of a sudden you've got a cup and a half, and that is a big potassium load, and also it doesn't contain as much fiber, right? I would much prefer that you actually ate the orange rather than drank the juice. And if you've ever made orange juice at home, it takes a lot of oranges to make a little bit of juice. And so, and you're getting rid of all of the fiber while you go get rid of all the pulp. So thank you for saying that. I much prefer the consumption of the whole fruit. I think people go to these juicing bars and all of a sudden they're getting these large volumes, and those are the ones that really do still concern me with respect to the potassium load.
And I'm positive that glasses and cups are larger in Texas than in Innsbruck and Frankfurt, I guess. Huh?
Exactly.
Yes.
Dr. Clegg, do you have any comment about the noni juice, 56 milliequivalents of potassium?
We just recently saw a noni plant and saw the noni juice, but it's one of those that's exceptionally high. And those are the types of things that, some patients might have heard through, their family history. Oh, this is a really healthy juice to consume. And if you don't actually begin to talk to them about what they are consuming, you might have missed that they're drinking noni juice with their RAS blocker. I have no idea, but you never know what they're actually consuming because there's a lot of wives' tales that are associated with some of the products.
Are there any good websites for patients in the US and then surely also in Europe, even though our food is surely different from the one in the US, so that you recommend to your patients that they may refer to at home to check their dietary intake with regard to potassium and maybe also surely to phosphorus intake?
It's a great question. And I would say that the ones that are associated with like the National Kidney Foundation and the like are really great websites. The American Dietetic Association or Nutrition Society, not quite as great. I would say I would stick more to the nephrology websites are doing a much better job of beginning to embrace this concept that we need to relook at the fruits and or the overall dietary consumption. One of the things that I found quite interesting is that in the United States, they did an analysis of the amount of potassium that people are typically consuming. And actually, potassium then was listed as a nutrient of concern, not because we're consuming too much, but because we're consuming not even barely enough. And as a matter of fact, most people in the United States are already eating an incredibly low potassium diet. And that's one of the reasons too that I think we need to ask our patients, what are you actually eating? Maybe we don't have to restrict. Maybe they're already on a 2000 milligram potassium restricted diet. And then when we tell them to restrict further, they're really confused. So I think that again, it comes back to there will be much more of this information that'll be, making it out there to the web. But I would say that utilizing the National Kidney Foundation and all the nephrology sites is the best recommendation for nutrition and information.
Thank you. And then the last question on diet. So how comes that global warming is associated with changes in potassium of our food?
Isn't that amazing? So I was reading this article and it was talking about the fact that it's adding some acid levels to the soil just due to the acid rain. And that then changes the overall plant content of potassium. And so that it's actually significantly lower than it was back in the day when we did all of the potassium content of the foods. So I think some of these lists that we now use, I think they were probably done like I don't even know how they were done, like in some sort of machine where they analyzed the potassium content, but those were done years and years ago. And so it would be really interesting to go back. It's one of those studies that I'm not sure the National Institutes of Health or anyone's ever going to really pay for, but I would love to know, does that orange today have the same potassium content that the orange of yesterday had? It's grown, okay, it's much larger now, but does it have the same? And because we're using hot houses, we're utilizing all these different techniques to grow our fruits and vegetables, I do wonder whether the potassium content that's listed is actually accurate.
Thank you.
Thank you.
So there may be some questions on medication and treatment. And again, Dr. Palmer, you pointed out the importance of SGLT2 inhibitors. Now we are close to the ERA meeting. We will see the flow data in a couple of days, I guess. Do we already know whether GLP-1 agonist or one of the double or even triple agonist may also affect potassium levels? You mentioned that glucagon may affect potassium excretion. So do we have good data here?
Yeah, that's an interesting question. I'm not aware of any specific effect of GLP-1 agonists on K homeostasis, except perhaps through the mechanism that you mentioned, although I'm not familiar with any specific effect of those drugs. And so again, it was just the SGLT2 through the mechanisms that we reviewed. But it's a great question. And, I think exactly how all of these drugs are working to bring about weight loss and improvement in metabolic homeostasis, I think we're only now still continuing to uncover, but I don't know any specific effects on K.
So we have to wait a couple of days before flow will be presented, and then we get the answer then. What about aldosterone blockers? So there are actually two opinions. There are those who say, well, finerenone may induce less increases in potassium. Others who say, well, it's just a weaker blocker of aldosterone receptors, and therefore the lesser occurrence of hyperkalemia may just be caused by this lesser dosages. We have phase 2 studies which actually show that finerenone in higher dosages is quite similar to eplerenone. So do you believe this is actually one drug with different dosages or two different drugs?
Yeah, again, my take on that literature is I think it's a pharmacokinetic difference. For example, take spironolactone. As you well know, that number one has a very long half-life, and it has active metabolites that inhibit potassium secretion that have been detected in the urine for as much as 2 to 3 weeks after somebody's been on chronic spironolactone. You compare that to a drug like finerenone, it has a half-life measured in hours with no active metabolites. So I think a lot of the differences in tendency towards hyperkalemia that may exist relate to those kinds of differences. With finerenone, there's no active metabolites and it's a much shorter acting drug. And so perhaps should there be a difference in the tendency towards hyperkalemia, I think that accounts for those differences.
Thank you.
Yeah.
And then with regard to diuretics, in your paper, you clearly state that surely for chronic hyperkalemia, they are important for volume control, whereas in acute hyperkalemia, we should be rather reluctant and to avoid volume depletion. So we should really distinguish these two entities before deciding whether or not to apply diuretics here.
Yeah, so obviously in a chronic patient, these are almost always going to be somebody with some degree of chronic kidney disease. And because volume is such an issue, particularly in trying to control blood pressure, the diuretics are really serving a lot of good purposes, not only helping to minimize hyperkalemia, but they're part of a regimen to help control blood pressure. In the setting of an acute kidney injury, obviously, the use of a high-dose diuretic might induce further volume contraction that could propagate the kidney injury. I mean, it's a totally different setting, I think, as you're pointing out. And so, yeah, I think you have to individualize it in that setting.
Which is very important because I think many people automatically turn towards diuretics when they see people with increased potassium. And then I was astonished to hear from you and to read from you that people with diabetes mellitus have actually a low renin-angiotensin system. Normally, we tend to believe that every hormone system is activated in diabetes. So this looks like the contrary. Are there any good explanations for this? Why do diabetic patients have rather low renin-angiotensin activation?
Well, I think it turns out that my reading of the literature, it's been a while since I specifically looked at this issue, but diabetic individuals, particularly even in the setting of normal kidney function, tend to have more of a salt-sensitive form of hypertension. So suggesting that they're slightly volume expanded. And so obviously, should there be any decreased kidney function, that degree of expansion is even further augmented. So yeah, I think hyporeninemic hypoaldosteronism is a feature of diabetes, particularly with any loss of kidney function. Obviously, ACE and ACE ARBs, they still are obviously kidney protective. And, you know, many people say perhaps we're targeting more of that intrarenal system. You know, you could still have a suppressed circulating system and yet angiotensin II be produced locally, and that's really what you're targeting with these therapies. So, but yeah, I think low renin, low aldo is a very characteristic state of diabetes mellitus.
Would you recommend to measure renin aldosterone in these patients with hyperkalemia, or to measure urine potassium? Because we usually do this in hypokalemia to see whether it's renal or gastrointestinal losses. Any role for doing these measurements in hyperkalemia?
You know, people have asked me that before, and I think not. I mean, I think there is a role in hypokalemia. You know, we try to distinguish kidney wasting versus extra kidney wasting. But, you know, when you think about it, hyperkalemia, 99% of the time, it's a kidney problem. You know, in the absence of acute cell injury, rhabdo, those kinds of things. Chronic hyperkalemia is virtually always a kidney problem. So to measure renin and aldo, I just don't think it adds much. Hypokalemia, there may be a role, but not hyperkalemia. That's just my personal opinion. I think the clinical setting can allow you to make that distinction. Yeah.
Thank you. And then my last academic question. We just saw the publication of the new KDIGO guidelines on chronic kidney disease that are much more reluctant on bicarbonate substitution in advanced CKD, and that lowered actually the target for bicarbonate in the serum from, I guess, 22 or so to 18 millimoles. Do you believe this might increase the rate of hyperkalemia that we will see in these patients, or are you not afraid of that?
Yeah, I'm not sure what the rationale was to lower the value. Would it be, in my opinion, yeah, I think it might, you know, be one of a small factor that could possibly increase the risk. I guess I've always been or more impressed with that literature that chronic acidemia could play a role in the progression of CKD, you know, and that correcting metabolic acidosis may have favorable effects in slowing CKD progression, you know, perhaps through less complement activation because you're suppressing ammonia production, less renin angiotensin activation. The studies of Don Wesson, he's published in that area. Yeah, I'm a little surprised that they've become more relaxed in that area.
Unless they're becoming more relaxed in the diet, right? So such that you're eating a fresh fruit and vegetable diet, then you're going to get the benefits of not having as much acid load, and that could actually provide a large amount of benefits. So maybe they're embracing the diet as a way of correcting acid-base balance, and that would be a good thing. So.
Yeah, that's a good point. I mean, fruits and vegetables are an alkaline load, and again, the studies by Wesson and Goroya, they showed that if you gave sodium bicarbonate tablets or a diet enriched in fruits and vegetables, it had equal efficacy in the protective effect on CKD progression. So I'm not, again, yeah, I'm a little surprised they've lowered the threshold down to 18.
And as a little cliffhanger, we will address this topic in a couple of weeks. Cliffhanger in double sense, so because at the end I'm eager to learn. I know that Andreas Krumbichler surely does mountaineering because he lives in Innsbruck and he's surrounded by the Alps. But if I looked behind you through your window, and I've never been to Western Texas, but it looks flat. And how does one become a mountaineer, and why did you start and actually did all this mountaineering? So I'm curious to learn.
Yeah, so my window is deceptive. So here is Mexico out my window, right? Not New Mexico, actual Mexico, and it's pretty flat. But if you were to look to this direction, I have huge mountains. We're actually as tall as Denver, it's in the Colorado Rockies. So we have really, really big mountains here in El Paso. Now in Dallas, where Dr. Palmer lives, there's nothing. It's flat as a pancake. So how did I get involved in mountaineering? Well, I actually got involved when I had the opportunity to go over to Europe and just fell in love with the Alps, to be honest, and absolutely loved all the hiking that I was able to do when I was living there. I actually lived in Germany for a few years in the military. So that's really where I became fascinated with it. And then I've just enjoyed the experience. There's something just totally amazing when you get to the top of a mountain. It's unlike anything that you can experience. It's an achievement. It's been challenging, but you get there and it's all worthwhile to see the beauty from at the top of the mountain, and it's almost like a religious experience in having that opportunity to do that, and to be involved in, you know, climbing through all the different climatic zones. I remember we've done Kilimanjaro, and it was just like you go through all of these different phases, and it's just, and you get up to the top and it's bitterly cold, but it's just a phenomenal experience. And so the way that I train here is either I go up and down the mountains, or I climb the stairs in the buildings to keep my activity level high. So I'll pass it over to Dr. Palmer.
Yeah, I mean, you know, people always ask how I became interested in mountaineering. And the first thing I would point out is I never started until I was in my mid-40s. And prior to that, really didn't do much of anything physically. But I kind of watched these shows about mountaineering expeditions and just became fascinated with it and decided to give it a shot. But the lesson I would share with the audience, it's never too late to start something. I like I say, mid-40s. And from that point on, went on to be able to climb the so-called 7 summits. Again, like Dr. Clegg, I did a lot of my training here in the tall buildings in Dallas because it's flat. I'd always put a little bit of peritoneal dialysis fluid in my pack just to kind of get accustomed to carrying weight.
And again, there are great YouTube videos where you show photos of your different summits. My very last question, actually. So when comparing these 7 summits, so for me, it's incredible to climb any of them. I have once been on the highest point of Belgium, which is 600 meters, and that's all my mountaineering experience. But so it looks as if the Kilimanjaro might be the easiest one. But again, I have no idea. So I would be curious to learn from you, comparing these 7 climbs, which was the toughest, and maybe also which was the less toughest one.
Yeah. I mean, boy, you know, Kilimanjaro, you know, anything that, now again, in the United States, we always talk about feet. It's 19,000 feet. And no matter how easy the climb may appear, once you get to those kinds of altitudes, it can be challenging, you know. But in terms of some of the more difficult ones, Denali in Alaska is a tough climb because it's very far north. The weather is very unpredictable. And I remember on that expedition, many days stuck in a tent waiting for weather windows to go up. And in fact, you know, one of the biggest challenges I have found in mountaineering is just the delays, being kept in a tent waiting for weather opportunities. And that mountain was really challenging in that regard. Obviously, Everest, you know, because of its altitude and the height was clearly a challenge. But one of the climbs that Dr. Clegg and I actually did together that we really enjoyed was Mont Blanc. And that we found that was a challenge, the way people typically do it, all within 24 hours going all the way. But we certainly like the huts. Debbie, what do you think?
Yeah, no, I agree. I think for me, Mont Blanc was really challenging. It brought into, it had multiple different types of climbs. It was just like a slog, and then there was some rock climbing, and then there's some scrambling, and it was cold and windy, and there was a knife ridge. So it had a little bit of everything. But I think every mountain that we do, we learn something new about ourselves. And so, you know, it pushes us outside those boundaries. There's one in outside of Ecuador that has just been the bane of my existence. I've tried it multiple times, and I will win. At some point, I will win. But yeah, so it's just I think it's all that just put in together and the challenge.
I think you're completely right. So the mountains will survive us. So you have plenty of opportunities to get to the top. And I completely agree. You know, it's such a relief if you stand at the peak and you can just watch, you know, your surrounding and enjoy the silence. It's amazing. I completely agree.
Completely agree.
One of the things they say in mountaineering is you're not having fun unless you're suffering. And so we always have a lot of fun on these climbs.
Which is somewhat like academic medicine, isn't it?
Absolutely.
And sometimes also clinical medicine, actually, yeah.
Very good analogy. I like that.
So thanks so much. That was fascinating. Thanks so much for writing all these great papers. Thanks surely also for taking the time for being our guest for 1 hour. And this has been really inspiring work. Thank you. And hopefully meeting you once again.
Thank you very much.
Lovely. Thank you so much.
Thank
Have
you.
a blessed day. All right. Take care.
Bye.
Bye. Bye.